I'm Danielle Morin, I'm a nurse consultant, and Suzanne Dumais is the quit smoking nurse. She's going to come up a bit later to discuss how she works with patients. Basically, when they come to the quit smoking center, they can get also to work out their strategies. It's up to the patient to decide if he wants, when he wants, but the motivational interviewing has the patient discuss his reasons to quit. We can think it's a good reason for him to quit, but basically the patient has to be really, I'm sorry? Motivated. Yeah, it has to be motivated. He has to be motivated, but because it's a drug, it's very difficult for people to quit smoking, and they've been trying many times in their lives. So oftentimes when you meet patients in a clinical setting, they say to you they're not interested in quitting smoking because they've gone through it, they've failed, they've relapsed, so they don't really feel confident. That's what we try to work with them. In your context, that's not exactly what you should do. You're seeing patients for a short time, so that's why we talk about treating nicotine addiction, because the patient has to be offered something to fight off his side effects, his withdrawal symptom. So just a few numbers to say, we saw all the risks. When we think about cigarettes, we think about cancer, but there's a lot of new diseases that have been found to be related to cigarette smoking: infertility, ectopic pregnancy, tuberculosis, age-related macular degeneration. So it's not just about cancer now, it's about all of these other types of diseases that are being found. And actually 5 million deaths a year for tobacco smoking, and the poor countries, the cigarette companies are going in and bringing the cigarettes to them, so it's going to only go on to increase. Secondhand smoke is also an issue. Smokers tend to expose their families to secondhand smoke, and we need to sometimes ask them, are there smokers around you? Because one thing that doesn't help the person quit smoking is everybody else in the family is smoking in the house. So sometimes they'll be able to get the support, other times they're going to have to figure out why they want to quit smoking if their partner doesn't. So it's still a bit of an issue. And just remember that in a car, somebody that smokes in a car, the concentration of the smoke is 27% higher, 27 times, sorry, higher, and it's invisible. So people feel, oh, I'm going to open the window and my kids won't know. They're exposed because there's secondhand smoke, but there's the third-hand smoke, whatever sticks to the walls and the clothes is still a contaminant. So you know a lot about the costs, and this is just basically an introduction saying that $1.6 billion a year to treat patients that have been smoking and have smoking-related diseases. It's a lot of money for Quebec to be spending that. And even though patients have been smoking less, people have been smoking less, 50% of patients were smokers in Quebec in 1965. 30 years later, we've got down to 32. Now we're down to about 13% on the West Island, but still 45,000 people are smokers. So you'll end up seeing a lot of smokers once you ask them if they're smokers. Sometimes people will say, no, I'm not a smoker, because they feel guilty being in a hospital with a smoke-related disease. If you ask them if they have smokers in their environment, if they're exposed to secondhand smoke, sometimes then they open up and they tell you that they stopped but a week ago, a month ago, and they're still struggling. Even though the smoking rates have decreased, a lot more deaths every year. So we're kind of starting to see the impact, and it's not finishing because it's actually increasing the number of deaths on a yearly basis. Close to us in a hospital, why should you have your patients be treated for smoking? A lot of reasons that I wrote out, but you see less stress on the heart. Somebody was asking about the heart rate. In oncology, the research is so strong about less recurrence, better treatments are better supported by the patients, better 5-year survival rate. So really data and research data really is strong. We're working at St. Mary's at this point to have a program for the patients that come in. We're coming into the Lakeshore also because it's really important to get the patients to understand. Sometimes we feel, I'm going to upset the patient. Doesn't he have enough stress in his life? And really, I went to a conference and there was a panel of patients saying, we wish we would have known because our medication would have been more effective. It's not that we remove something from them to deal with their stress, but once they know the benefits, usually they start at least decreasing. And when patients quit smoking, they get to be hungrier, which is a great advantage for cancerology patients with the medication they get. Mental health, some medications can be decreased by half once they quit smoking. And they spend so much money. Dr. Gervais was saying like 100 cigarettes a day, like 3 packs a day. 1 pack a day is almost $4,000. Where do they get the money? Usually it really impacts on their lifestyle. Chronic disease, severe COPD, sometimes people say, oh, he's so sick, like is it worth it? For a patient to have just a bit of an increase in the lung capacity changes a lot of things for them. So it's up to them to decide. We could offer, but it's never too late to discuss smoking treatment. And some patients that were palliative said, I want to show an example to my family. I want to show I should have done this before. But also, the pain medication is more effective. So offer, we're not pushing anybody, but we're offering treatment. And at the hospital, that's exactly what we're trying to do with them. So a lot of data here you can read if you want to know more about all the research that's there. 20% of their patients here in clinical setting smoke. So on admission, really, they're motivated to quit smoking because something is happening to their health, and usually they're kind of vulnerable at that point. So they'll be open to getting at least treatment. They're restricted from going to smoke because sometimes like cardiology patient can't move around, and less they're encouraged to smoke beside the door. They don't have the usual triggers, and everybody that goes into the room can talk about quit smoking. As Dr. Gervais was saying, the inhalation therapists, the nutritionists, the pharmacists, the nurses, a whole team of us have the same message, so it's a coherent message. It's actually called a teachable moment, because that is when the patient is really open to making changes. He wants to get better, and sometimes they kind of feel, oh, I should have done this before. Cardiac patients, 65% of them are interested in quitting smoking. When they're outside in the community, only 20% want to do it. So you can see the impact of having an illness or a diagnostic that changes their feeling about it. So every interaction we have with them is a good time to ask them, are you interested in getting some NRT, like the nicotine replacement therapy, to help you deal with the withdrawal symptoms, and then we'll see if you want to go on further. And you might think that the patient's going to get mad. You're not the patient's family. You're a professional, and patients expect it from us. If we don't talk about quit smoking, it's almost as if we're saying, well, it's not that bad really, because if he wasn't taking his insulin, you'd talk about it. So the patient feels, oh, nobody's asking me. Okay, that's fine. So proven interventions, there was a lot of information on that. Basically, professionals are busy, so the quickest way is 3 questions. Our smoking status, we could help you fight off the urges to smoke, and I can prescribe for you. There's nursing prescription privileges, and when they leave the hospital, there's resources for them in the community at the CLSC, the phone. Dr. Gervais showed us the different resources. And more, what's being put into place is an opt-out strategy. It's not saying, okay, you're a smoker, would you like the nurse to come in to discuss smoking? The patient comes in and you say, you're a smoker, we can offer to treat you. If you have any side effects, how many cigarettes do you smoke? We kind of try to be more, it's in the continuum of care. It's not something that we're asking the patient. Patient that has a heart attack, we don't say, do you want to see a nutritionist? He will see one because he probably has something he can learn from her. Quit smoking is about the same. At St. Mary's, I was saying we're there. So once the patient's status is on file, then really the next step is to offer the nicotine replacement therapy. Since January 2016, nurses can now prescribe. You have to go to the ONQ site, do a 2-hour online training. Then these are the requisites to do the training and where you're going to be able to prescribe. It's a bit restricted at this point, but the baccalaureate nurse can prescribe of everything. The other nurses, it depends on what work you're in. Once you've had the prescription degree, then you can go in to do an NRT specialty training. At this point, only the ONQ is giving it, the OEQ, but we're coming in with something that's going to be done here exactly, because then it's a whole day over there and you might not need that much, and the level is not quite what we want. There's also a protocol here at the hospital, so if you want to read the protocol, they went through and described everything that they expect from nurses to do when we prescribe NRT. It's a professional responsibility. It's still a natural product, but they want to make sure that we know how to better care for the patient. So evaluate the patient's use. Once the patient says he's ready to quit, there are a few questions. We're working on harmonizing all the documents because through the CEUS, there were many different types of documents. So some of them are not updated, so we're working to update them. But basically, when does he smoke within 30 minutes of waking up? How many cigarettes a day? What has he used in the past? The evaluation papers will be available soon. Contraindications, it's still the ones that are found in the OEQ document. With the new data, we have to see if everything is pertinent, but basically, once you go around the precautions and the limits, if the patient has no contraindication, if you have the privilege to prescribe, you have to write both the prescriber number and the ONQ number. As Dr. Gervais said, doctors, nurses, pharmacists, pulmonary therapists, nutritionists, exercise therapists, everybody that really is interested in prescribing, we're going to have to use the pre-printed order. Nurses will be able to prescribe. The other professionals will have to use the pre-printed one. But all the algorithm, all the treatment schedule is on there, so you just have to tick off and you'll be able to use it and send it to the pharmacy once it's signed by a doctor, for sure. McGill guidelines, we saw that with Dr. Gervais. This is the Ottawa model guidelines. So again, everybody has their own way of adapting their own guidelines. They look at how much to give NRT if somebody smokes within 30 minutes of waiting or 30 minutes after. It's a bit of a complicated document. What we're working on, you see, as Dr. Gervais said, 40 cigarettes more, 42 milligrams of cigarette, and going down every week. So in the back of the document, there's going to be the replacement guidelines. So at this point, our document, we're going to go up to 40 cigarettes a day. It has to go through the pharmaceutical committee, so we're going to see how they feel about going higher than that. Maybe they'll want the patient to have more gums instead. But there's a limitation on the number of gums that can come through a prescription. Again, we're at the stages where everything has to be reviewed by the pharmaceutical experts here at the hospital. So this is what the pre-printed order would look like, used for prescription and for people that cannot prescribe it, can just suggest. Again, the importance of well signing. There are teaching tools in the OIQ document where how to teach the patient how to use the product. Some patients, for the gum, it's not actually a gum, it's more like a patch for the mouth. If they end up not using it well, they may not get the most benefit out of it. So that's why it's good to go over the way they're using the product. The vaporizer is one of the worst ones. They use it as a pump rather than spraying through the mouth. So go over how they're using it. It may be that they're not using it well and they may not need to increase the dose so much. What is recommended also is that some NRT, the short-acting one, the gums, the lozenges, be left at bedside. That is going to be an internal decision because some places they leave up to 10 gums or lozenges a day and the patient self-medicates. But the pharmacy and the doctors have to be open to that, and it depends on the individual patients for sure. So those are the other specialists or healthcare workers we're going to be working in as a team. So smoking is not a bad habit. Quitting smoking is not about not being strong enough or not being tough enough. People that are able to quit without taking any NRT, they're very rare. Usually people need help, they need support, but you're going to know somebody that says, I was smoking 2 packs a day, my wife got sick, stopped all of a sudden. Usually people need support and need NRT. The government covers 12 weeks. That does not count the weeks that are in the hospital. When they're here, they're paid by the hospital. When they get out, they have their 12 weeks. They may need years of NRT. Like you don't go from 90 cigarettes a day in 12 weeks to nothing. So it's going to be a process because a lot of it is related to activities. Smoke with a coffee, smoke with friends, smoke when they're lonely. So all that they have to deprogram also. We have the brochure that we came up with that was produced by the Communication. You could give some patients the information. We're trying to be very brief to really get them maximum information in a small pamphlet. So French and English. We have one also for cancer patients. We're going to be developing one for pre-op. More and more. So at the end of my presentation, there's a lot of reference that you can look at from NRT research for all types of cancer. So that's pretty much what I had to say today. Anybody have questions for me or for Dr. Gervais?
So
Yes?
from what I understand, you will be offering a course to the nurses so that they can be comfortable in prescribing?
Yes.
This is a quick thing today so that you're aware. Because it really goes on how many cigarettes the patient is having and how many symptoms he's having of withdrawal. But if the patient has a patch and a gum and he still feels like he wants to smoke, he's not getting enough. There's really no risk. The patient is self-dosing himself because what they get out of the cigarette is usually much higher than what they would get out of a patch. And because patients remove the patch at night, often because they have dreams, so if they're sleeping 6 hours, they're actually losing a quarter of the dose that's on the patch. So we're giving them 21 milligram for 20 cigarettes, but they're actually getting 15. They wake up in the morning, they put on the patch, takes about an hour, half an hour to an hour for the patient to really feel better because he has this urge to smoke when he gets up. So we recommend a gum, a lozenge. People have had bad experiences. They say, I tried the patch and I felt so ill, I didn't feel well. They were probably still having withdrawal symptoms because we were not doing combination a few years back. So yes, we'll be giving a class so people feel comfortable. And then there's going to be phone lines where you can call. I'm going to be probably available for that. Suzanne Dumais, who's the quit smoking nurse, she's going to come up to discuss a bit her work at the smoking cessation department because she sees patients. I'm going to let her talk about her work as a smoking specialist.
So I'm Suzanne Dumais. I'm a nurse clinician trained specially by Dr. Gervais to help support our clients in quitting smoking. So sometimes it's not only in quitting smoking as well. To get them to see me, sometimes it's talking about cessation, like decreasing the number of cigarettes, or seeing how they're feeling about what their experiences has been in the past. So sometimes to get them through my door, we get the best way, to be honest, is the direct referrals. So for instance, Chantal refers me a lot of patients who come. They don't always want to quit. I often hear you have to be motivated to come and see me. Usually the clients who are motivated to quit can often do it on their own with minimal support with the pharmacist, their physician. I see the clients who are really struggling. So people who have been trying for 20 years. I saw a man who came to see me. He says, you know, this nicotine gum, it doesn't work. I've been trying for 20 years to quit. And I said, well, show me how you use it. And when I reviewed it with him, he quit within a week. So there's a lot of different examples that we see. I would say a majority of people who come through the door are not using enough of the nicotine replacement, and they're not using it effectively. And so it's trying to get them to use it. A lot of people are resistant to using nicotine. They're saying, oh no, I want to do cold turkey. Well, we know cold turkey, the success rate is somewhere around 1 to 5%. So it's not that successful, cold turkey. So what we try to do is help them feel more in control. Because essentially that's what they want. They want to feel in control of their lives. And smoking makes them feel out of control 20 times a day if they're a 20-day smoker, cigarette smoker. So by getting them to feel, okay, what do I do when I have that craving all day long? Once we learn how to manage that with the nicotine replacement products, with the counseling, with what's going on in their lives, a lot of people say, I'll have to wait until my life gets easier. I don't think, it usually never does. It usually gets more complicated and people don't feel well. And oftentimes, oh, I'm so stressed, I can't quit smoking now. So actually, when you do quit smoking, I would say virtually all of my patients, a lot of them have anxiety and a lot of stress, and once they quit, their stress levels and anxiety levels have gone down. Why? Because they're no longer experiencing withdrawal all day long. So these are little things that really help people move forward, and it takes the time it takes. I think that last line is really the key, is we support them. There's not one smoker who will quit the same way in my office, and so I try to really tailor their quitting and their process according to what they need. And some people, it's been taking 3 years, some people in 3 visits, and they're done. So it just depends what's going on and what we need to do to help them. Any questions?
Is there any family plan for the people that have like health issue, smoker, but they have like partner, other member of the family who smoke? So it's going to benefit them not only if they quit, but their
So non-smokers, you're saying, who have a family member who smokes, or the families who smoke? So I do see couples, a lot of couples, a little bit of couple counseling at the same time. But so I really see a lot of couples. Sometimes I'll see like a mother and daughter. And we also offer group support, so the families could come to the whole group. But
I don't have like a plan, like a special way to invite them, no? Because like I had in COPD clinic, I had a client, specific client that was living with her daughter and son-in-law. So she was always trying to quit, but because those couple were smoking, it was totally difficult for her. So it's not like, it's not the partner, it's not the conjoint, it's the daughter. And
so I do see that quite frequently, where one person in the family is a smoker, they all smoke, and then one needs to quit or wants to quit. It is tricky if they don't want to come in and see me. I can't but sometimes we do work on trying to find strategies that will make them feel more powerful or empower them when they're in those situations. So when you're at home, maybe there's certain rules or boundaries that could be set, where the smoking could be outside, or negotiating with family members on what could do as a step to help them, support them. And so I do invite family members to come sometimes to hear, you know, the little spiel that we give, so that they understand that nicotine dependency is a chronic disease. And as such, it needs to be treated as a chronic disease with all the support. So we try, and maybe we can build on that some more. Sounds like it's a big need.
One of the issues that we've sort of touched on a little bit when we were talking about the oncology department is you know, increase of appetite and people's fears of weight gain. It's a big issue with getting people to stop smoking.
So one of the best strategies is really managing their nicotine withdrawal so that they're less hungry, because one of the effects of nicotine withdrawal is increased appetite for sugar. So for sweets. So that's for sure there is a percentage of weight gain. That's Dr. Javet can speak more to that, but we do try things like increasing the dopamine naturally by activity and promoting those activities. So in general, I have one client who just quit. That was her fear of gaining weight, and her husband, she actually also had a fear of going to a doctor. She had a fear because she thought she had lung problems, and she was afraid of quitting. She was afraid of everything. So now she's quit, and she realizes her fears have gone down because her anxiety has gone down now that she's not, you know, full of nicotine. And she goes for a walk with her husband every day and has found a family doctor, all in the space of 2 months. And this is just from 3 or 4 visits that are, I mean, it's not always so wonderful, but that's a wonderful example of so we do try to promote lifestyle. It's not just the quitting smoking. The quitting smoking is often open as a door. I had one client, it was a wonderful story. He was having a lot of problems with his daughter, a teenage daughter, relationship issues with his wife, stress. He was very stressed at work. And so he says, I don't know if I should try. I said, let's give it a try. So he quit smoking. He was able to do it. His relationships with his employees at work were improved because he wasn't so irritable, because he said, well, I'm using my products, I'm fine. I'm active now. I go for walks with my dog all the time. My wife has decided to join me and has decided to quit. And my daughter and I are getting along because she had an addiction issue to drugs, and she's seeing that I quit nicotine, which is higher addictive than cocaine or heroin. So it was very inspiring for her. He says, I can't believe how my life has changed by making all these changes. It was to quit smoking, but essentially my whole life kind of opened up. Because if you're smoking 20 cigarettes a day, that takes a lot of time. So you have to figure out a different way to fill that space.
When you're talking about managing withdrawal symptoms, that sounds like it has to be kind of individually tailor-made,
exactly.
Right?
Yeah.
So, I mean, what would you do? Like, would you have the person become more aware of the withdrawal symptoms? Would you have like a diary or a log? Or
so again, it depends on the person in front of me and where they're at and what their story is. Sometimes what we start off with is a smoking journal to figure out when they smoke, What are their habits? What are their moods? What are their triggers? So we have a better picture. Just take one day in your life, maybe during the week, maybe another time on the weekend. So I have a lot of people during the week, they're very stressed at work, they smoke more. During the weekend, they're actually more active and they smoke less. Or it could be the reverse, depending on what's going on. So then we look at, okay, well, how many cigarettes do you smoke? And we try to prescribe the patch. So I can prescribe the patch, and then we look at, make sure that their levels of nicotine are at a good level. If they're having withdrawals, so it's about educating them with withdrawal. And they say, well, I'm still craving cigarettes. Well, sometimes you can still, you know, you can't be perfect the first few weeks. If you have a slip of cigarettes, in the past a lot of people would rip off their patch and have a few cigarettes, and then they start smoking a pack again. They go, this stuff doesn't work. I say, look, if you have a craving, that usually means that we're not getting enough nicotine replacement. So let's figure out how to manage that. So we can either up your doses or take it a little bit more regularly, your gum. So maybe take it every 1 to 2 hours. Don't wait for the craving to be a 10 before you take it.
Okay, so we're at the point where you're getting more, you know, you're adding more nicotine by patch and gum.
Right.
You're stopping the actual smoking, okay? At what point do you start, like, taking down the nicotine patch?
So it usually the recommendation is 6 weeks, 4 weeks, to 6 weeks with 21, 4 weeks with, but we really go with, I really tailor it to what's going on with the patient. So what we try to do with our clients is like, okay, so I'll see them just before they go, just after they go down to, or just before they go down to 4 weeks to like a 14 milligram patch. And then we say, okay, so how are you doing? When you go down, we usually suggest for the first few days, increase your gum or your lozenges as needed. But in general, it happens naturally, like Dr. Gervais says. They actually forget to take their gum. They don't need it. Or they forget one day to put on their patch. So it's like, oh, and how did you manage that? So then they realize, oh, my craving was, oh, and the patch had fallen off. So like they learn how to manage and be in control of their lives using the nicotine replacement products, but also saying, well, maybe I need to go for a walk, you know? I need to get up and do my dishes. I had one client, her cravings were increasing. She was actually hungry. And she realized that if she cooked supper a half an hour earlier, that she was fine with her cravings. Another one is she would stay up till midnight and she'd have more cravings and smoke at night. Well, her bedtime got brought up to like 11 o'clock slowly, then 10 o'clock, and she realized she didn't have any cravings. And fatigue is another withdrawal symptom, so that was kind of worked out well. So she was able to go to bed earlier, and that was a great strategy for her. And once your brain and your routine gets used to that, and then you sort of kind of wean yourself off slowly to the nicotine replacement products. Now granted, I always encourage all my clients to make sure they have a lozenge or a gum with them at all times, even after they're off the patch. If they have a crisis or whatever, they have something to go to as a backup.
That spray seems to be for certain patients like that immediate hit, right. You know, but it's not covered.
No.
How much does it cost?
I think it depends where you go. I know there's certain pharmacies and places that I know you can get it too for Dr. That has an answer to that.
The cheapest is Costco.
I was going to say that, but I don't know if I could.
2 for $55.
Yeah, it's about, I think, almost half of what you pay in pharmacies. Maybe M. Bourguignon would know more, but for my patients, that's what they told me, that the best deal was there.
But how long does that last?
There are 105 doses in each quick mist vaporizer. 105 doses.
And where I like those a lot in the morning, they're not everybody loves them, but a lot of my clients, they find especially in the morning when they first wake up and they have a very strong craving, it's really great. And then it takes a few days to get used to them. And once they're used to them and they realize that they feel more relaxed once they use it, it's often a nice tool.
You're talking about the vaporizer?
The Vapo Mist,
okay.
yeah.
So would you use that while you're waiting for your patch to kick in?
For sure.
That kind of thing?
For sure. And what's nice about it in the morning is sometimes, you know, we say maybe think about giving up some of your triggers like coffee and a cigarette. Some people, if I ask them to quit smoking and give up coffee, it's like, oh my gosh. So what I'll say is like, you know what, do a spray where you go to the washer. As soon as you wake up, have that ready. And then if you still have a craving, you can do another one. And then afterwards, because you're just kind of loading up your system, and then afterwards, if you want to have a coffee later after 5 minutes, because with these products, we don't encourage you to eat or drink while you have it in your mouth, but with the spray after 5 minutes, you should be good to go with your coffee.
Is there any medication adjustment, other medication, like heart medication, other medications adjustment after a client quitted smoking?
So maybe Dr. Javet could speak to this.
Definitely. If you are on a lot of medications, you have to check, because when you smoke, you activate all the cytochrome P450s, so you metabolize a lot of the medications more quickly. So when you stop, you return to normal. Which means,
or how long after?
it's usually when you've stopped completely, within the days, weeks. And that may be true for a lot of the sedatives, benzos, patients, if you don't adjust the doses, antidepressants, antipsychotics. Actually, at CNAD, when they instituted their non-smoking policy, they saved, I don't know how many thousands of dollars on medications, because the doses of antipsychotics had to be decreased on all the patients.
So is it part of your program to tell them, okay, now you have to go see the doctor?
Yeah.
Actually, a physician should know, if a patient has a long list of medications, he should know that the patient has stopped smoking completely. Anticoagulants as well. Diabetics. When you smoke, you increase the blood sugar. So when you stop smoking, your blood sugar will drop. So if you're taking insulin, you're taking oral hypoglycemics, they may all have an impact. The most frequent one is not even a prescribed drug, it's caffeine. And you'll need about 30 to 40% less coffee to get the same blood level of caffeine. And that's a very important one, because if you don't know that, patients may feel jittery, and you may think that it's withdrawal symptom, and what they have is an overdose of caffeine. So it's important to tell them that they will need less. Caffeine is in chocolate, it's in tea, of course, it's in soft drinks. So you have to warn them to maybe not stop completely their caffeine intake, but that they're likely to need less caffeine, and that also helps. So that's part of all the recommendations that have to be given. And for sure, a physician should know, somebody who's got a long list of medication, that his patient has stopped smoking. It's very important.
And actually, your coffee point, I see it a lot, where people are very jittery and very nervous, and they said, oh, I thought I would be less anxious. So we do take a look at the coffee intake, and we suggest either to maybe put 50% decaf and 50% regular. And I suggest to mix it up if they're open to that.
Actually, in the old days, less frequent now, but people would think they were giving too much nicotine replacement. And people would get a patch of 21, and the patient would come back and say, I'm jittery, and I've got a bit of nausea and a bit of headache, and they would stop the patch or decrease the dose, saying we're overdosing it. Now, people are less worried about overdosing, but the big worry was that they were going to kill them with the nicotine replacement, and that it wasn't the cigarette that was going to kill them, but the nicotine replacement. Most of the time they're underdosed, unless you start somebody who smokes 5 cigarettes a day on the 21 milligram patch. You don't overdose a patient very rarely with a 21 milligram patch, unless you give it to somebody who's not a smoker, not a daily smoker, or smokes very little. And so there's confusion between coffee, overdose of coffee, too little medication, withdrawal symptoms. Usually it's that they're not getting enough nicotine replacement, not too much. But in the past, that has been a very frequent behavior, was that we stop the nicotine replacement, patients are getting an overdose of nicotine, which I don't think I've ever seen, except in somebody who would smoke 5 cigarettes a day was prescribed a patch of 21. Because patients adjust their nicotine to their need if it's a PRN. They never overdose.
So just before we finish, I want to let you know that there's prescription pads to send the patients to the quit smoking center, not to prescribe the NRT. We also have these pamphlets you can give your patients, and you can call us or send us an email if you need more. They're bilingual, and the phone number for the quit smoking center is there. And we have also referrals that you can fax in. Eventually, it's going to be online. So anytime you feel you want to send the patient, then Suzanne is available. She works West Island and St. Mary's.
Thank you.
Merci.